Okay, it's about 12:45. I'm very pleased to see so many bright faces looking at me. I know it's Friday and there was a big night out last night and we're in Las Vegas, so thank you very much for staying and joining me today. My name is Hannah Tukalski and I am the Director of Quality Population Health and Data Analytics at a large size federally qualified health center system in the San Francisco Bay Area. Really excited to be in front of you today, and I see a lot of people with bags. I too have my bags, and will be dashing out of here for the airport at around 2, so hoping to get through the slides and then have a good, hopefully 25 minutes or so to answer questions, and then I'll plan on sticking around for maybe 10 minutes after, but I do have my contact information in the last slide, so I certainly encourage you to get in touch with me via email or LinkedIn, and I love talking shop about all of this stuff, so would really love to connect with you outside of TC19 as well. Two things about me that I think is important for you to know. It's November 15th, and a year ago, November 15th, 2018, I was about 1 month into managing a data analytics department. About, I would say, October 1st of 2018, I learned what data analytics was. I had no idea what SQL was. You know, of course, I had worked in Excel a little bit in grad school and whatnot, but really not a data analyst, nor do I propose to know anything about the technical side of what I'm going to show you today. But I have my right-hand man, Terwei Wang, right here. In case anybody has any technical questions, I will gladly defer to him. The other thing that you should know about me is that November 15th, 2018, I was discharged from the hospital after a very easy baby delivery, and so I am actually here for my daughter's first birthday. So since I couldn't be with her, which she's not gonna remember, so judge me if you will, but I think she'll be fine. I did intersperse some pictures of her in this slide deck to help me tell the story. So when you see some baby faces, that's the deal with that. So happy birthday to her. So let's dive right in. So LifeLong Medical Care, as I mentioned, we are what you would consider a large-size community health system. We serve about 65,000 patients in a year, close to 300,000 visits. If you just look at the graphic right there, you can see the San Francisco Bay, and you can see that we have clinics pretty much interlaced around all of sort of the hot pocket areas of the news related to community health or public health in the San Francisco Bay Area. So Oakland, Berkeley, East Oakland, West Oakland, Berkeley, Hayward. We don't do anything in San Francisco proper, but we're connected to San Francisco through various networks. Our patient population, as you might expect for a federally qualified health center, we serve about 90%, that's stats a year old, about 90% of our patient population are either at or above the federal poverty level, and that is who we love to serve as a federally qualified health center. That means that we cannot and would not ever think of turning anyone away regardless of their ability to pay for their services. So the slides that I'm going to show you and sort of the story, I think, that will unfold today is really cannot be explained without that sort of context. Really, I want to start us off by just telling you a little bit about the people that I serve in my role as the clinical director and also the data director. So, LifeLong Medical Care, we're big for what we do, but we are also in the shadows of giants. So we have a very strong Blue Cross Blue Shield system. We have a Sutter Health system. We have Kaiser Permanente headquartered right in our doorstep. So, we have employees that have literally chosen to act in service for the public good for anywhere between 3 to 5 times less salary than they could get right next door. So when I think of data and how to really engage people with data, these are really the people that I'm trying to reach, the people who need tools to do their job and be more efficient and effective at their job, and also get them excited so that we can reduce turnover, hopefully improve employee satisfaction, and oh, by the way, improve clinical outcomes along the way. So really my question that I grappled with, as I said, starting from last October when I took over this sort of nascent data analytics program at our health system and wearing kind of my clinical hat, was really how can we use data to support, or I like to think of it as like a warm blanket around these people. How can we use data to cuddle these hardworking folks? So that was kind of the question that I was really grappling with. And somehow articulated this well enough to hire Tearway, who really helped me build out all of what I'll show you today. So where did we start? So we started basically with 3 pretty sizable issues. Again, just for context sake, I think are important to get into. And it could be said we were living in the dark days of data. So we had at best month-old static reports that would be sort of automatically triggered from our EHR that would be posted, sometimes, if we were lucky, posted in a break room at any one of our 16 primary care sites. I'll show you a picture of this in a moment. The timeliness, let alone everything else you'll see on the images, was really an issue because obviously, as you data people know, if your data is that old, it's almost like you may as well not show people data, because by the time you give them, hey, here's your gap to goal and here's what you need to do to improve, they've already seen a whole other month of patients, they've been repeating that same mistake for 31 more days. It's really just not a good conversation starter. So that was one thing that was sort of a hindrance, if you will, to building the program that we have now. The second part of it was this data was in no way personalized. So it was really, by clinic, by quality measure, and who's to say that Dr. Jones is not carrying the entire clinic with his quality performance, or who's to say Dr. Jones is totally tanking the entire clinic with his quality performance. There was just no way to know. And so it really did not lend itself to any kind of intelligent conversation around performance improvement, because everyone could always just say, oh, that's him. I'm doing great. What do you mean? That's totally him bringing us down. That was definitely a barrier. The third thing is really this whole idea of black box reports, right? So we're all data people. We're here. We've homegrown our own reports on Tableau, and this is a huge, huge benefactor to this kind of program that we built at LifeLong, because with Tableau, that allows us to really be the masters and mistresses of our own domain, right? We can, if something is fixed, we know exactly how to go in and pull a different indicator or do whatever we need to do to perfect the report. Well, when you're getting these month-old, push-a-button reports from NextGen or ECW or even Epic, you don't know what is going on in the back end. It's just spitting something out, and you can double check and triple check and have your friend check your fields of the query you built, but you really don't have any way to really validate the reports. And so what that did was that kind of made this safe space, I'll call it, for our conspiracy theorists. How many of you have conspiracy theorist providers out? Yes, good. So these are the types that are just, no matter what you put in front of them, they could look like a superstar, but no matter what you put in front of them, they say, I don't know about that. Something's wrong with that. That doesn't seem right to me. I saw this patient in here last week, and that was not her story, so that must not be the story for the rest of the population you're trying to show me today. So the whole idea of black box reports and our historical reliance on that, because, like I said, we did not have a data analytics department, we did not have a Tearway, we did not have a me, was really a hindrance. And again, I think sort of lent itself to this culture of, well, yeah, we might have some reports, but they're really, really not helpful to us, and no one is really coming to us and explaining or even improving them, let alone explaining how we can make them better with partnerships. So let's just ignore them. I'm going to show you a picture of what I was describing. So if you like over here, this is what I like to call, the 10 commandments of data. It's just kind of like, it's like a really heavy anvil of lines of text and numbers. You see over here, there's a little bit of shading. Who knows what that is? I have no idea what that shading means. There's some images that look like some sort of calligraphy from an ancient time. Again, not defined. I'm so sorry that people had to look at this in their break room for quite frankly, many years. You see some run charts over here. At least these have axes of some kind. But again, this is all, over here it says cervical cancer screening. There's some months, and then there's some, there's like a performance line, and then 2 other lines. There's, again, no personalization. You don't even know what clinic you're looking at. I mean, anyway, it's just really not a very data savvy environment. So really, where do you go as someone who wants to bring their health system into the new frontier of data, or not even new? I would have been fine with like 1985 of data compared to what we had. So you really have to examine kind of the culture and the human element of what is perpetuating these issues. So quickly, 1, data entry. So obviously we all know your outputs are only as good as your inputs. We at LifeLong Medical Care, I'm so sorry to say, have had some historical issues with charting discreetly. This is not entirely our fault. We happen to option 2 EHRs that love the provider as a novelist idea and don't really appreciate the provider as a data partner profile. So, that's great, maybe for some, not for me. So we really had to grapple with how do we work on aligning around some standardized charting workflows. And you can bet, with everything I've told you in our story so far, that this was not easy, and we're still sort of working that out. But at least we're talking about it. 2, historical scope constraints. So, we want people who are licensed, and even our clinical support staff who are unlicensed, to be working at the top of their scope. We need medical assistants to be entering, A1C tests in the right place without, greater than or equal signs or dots, or, right? Like, we just need everyone to understand functionally the role that they play in documenting these quality measures, let alone providing the actual care to the patients. So this has been a major point of discussion for us as an organization. 3, and perhaps lastly, is really this idea of performance. So how many of you in the room work for an FQHC or community health or some sort of public health? Okay, so this should not be news to you. For those of you in the private sector, newsflash, those of us in these kinds of fields sometimes can have a challenging time kind of working with our people around this idea of performance, or any sort of report card, or how is he doing compared to her. And this is in somewhat part just because of our financial situation, right? Like, a lot of times performance is not tied to any sort of incentive, so there's not really like a whole lot of muscle under the conversation. And just in general, people, like I started to say in the beginning of my presentation, people choose places like LifeLong precisely because they're not interested in that performance environment. They want to have longer appointments with their patients. A lot of our provider base are family medicine docs or NPs, so they really came to us to be able to provide whole person care, as they like it. And so this whole idea of, hey, we're going to put your name up there with a number, and it was really it's sort of dicey. We're in a better place now, but it is something dicey that I'm sure many of you have experienced. So given all of these contextual things, I'm going to, in the interest of time, just launch into what we built. I'm not going to do a live demo. I'm just going to show you some screenshots. I will sort of work into the review of those slides, some of this and some of this context that we've just reviewed and kind of how that shaped what we did. And then, like I said at the end, if anyone has any particular technical questions or anything relative to the workbooks themselves, Terway or I would be happy to answer your questions after. So, what do you do in this environment where people are scared of seeing their name, they don't want to talk about performance, they don't want to chart in the right way, they want to write novels in their EHR? Let's have fun with this. So, came up with an idea around picking apples, because who in there, this is like, you know, hating puppies. Like, who can say no to apples, right? Everyone loves apples. So what would it look like to make a game out of clinical quality that is, P.S., like really low budget, not a lot of flashiness going on here, but just basically makes it fun to think of getting those PAPs done in a day. Makes it fun to document the A1C in the right place, because you know if you don't, you're not going to get credit for the Apple game, right? So that's really what we built. And I'm going to show you two kind of classes from our suite of tools. So there's the today's work, right, in reach, patients who are showing up for care. What did we do to kind of gamify and really elevate the core quality measure performance in that space, and then our comprehensive quality. So really things related to outreach or follow-up for patients who haven't been in for a while. So I'll show you both of those things. So this is our daily dashboard. And over the course of this, I'm going to show you all three of the tabs at the top. So the daily dashboard, the VAT, as it is knowingly called, which is that visit anticipation tool. Up there, and then missed opportunities. Now, to those of you who are way more advanced developers than we are, this probably just looks like a basic daily dashboard. There are your 10 core quality measures. There are your productivity stats. Whoop-de-doo, right? I'm going to show you something kind of fun. So, what we did is we built this thing called a visit anticipation apple tree. You will note, many of you, that these apple colors look eerily familiar to these core quality measures over here on the left. And that there is an apple in the basket, that there is an apple right here, we have a dictionary, so some kind of fun stuff going on. The basic premise of this game is that there are at the beginning of for whomever provider, at the beginning of the day or all throughout your day, there are any number of patients coming in who are due for these things, right? So if I'm looking at our friend Tev over here, so Tev is a nurse practitioner in our Howard Daniel Clinic. Tev can look at patients who have arrived or not, or everyone on her schedule for the day. She can look at today, or she can go back in time or forward in time. And again, I should note, this data is refreshed every 15 minutes. So Tev, or her medical assistant, or her nurse, can basically refresh this workbook and see newly populated data directly from our next-gen EHR that is, again, helping her plan for her day. So presumably, this is at 10:28 a.m., and they have made quite a lot of progress. So you see here, and again, it's not live, but you can see sort of the dynamic nature of the workbook. She and her medical assistant have actually picked the apples for 5 of the 7 measures that they had due today. So this effectively means, for example, for colorectal cancer screening, that all the people that were on her schedule that needed a FIT or a colonoscopy or Flex Sig, whatever it is. They got that done. Now they can pick the apple, and the apple automatically goes from the tree to the basket. You'll notice the size of the apples are a little different. So this is, again, another dynamic piece of this, that if you are doing what we recommend you do and checking in on this report every 15 minutes or so, you will notice the size of your apples changing. So the 2 here, the fact that the 2 for the diabetes apple is smaller than the 4 of the hypertension apple is because Tev and her medical assistant have effectively done or completed more of the diabetes, outstanding diabetes work that needed to be done for their patients on schedule that day. And 4 represents a larger proportion of the people on her schedule that needed some kind of hypertension treatment for the day. So, and here it is bigger. So I basically, going back to all of those things that my lovely daughter was helping us kind of process there about context, you know, this is not rocket science. The apples don't even come off of the tree in any sort of, you know, visualized way. You just look back every 15 minutes and you know you've just done 11 paps today and you had 11 on that tree, and by God, someone is watching and the apple actually gets picked from the tree. So talk about a way to reinforce trust or rebuild trust with providers, that someone is actually gathering the right data, is actually seeing what they're charting and rewarding them with this simple gesture, peace gesture, if you will, of we see you, you did great, you picked the apple from the basket. Now, presumably, you know, Tev and her medical assistant can use this as a huddle tool, right? So going back to the beginning of their day, they can look and they can say, okay, and this is, again, all providers, but let's pretend that this is just one provider and they have all these apples on the tree with how many they'll need for each one of these core quality measures. They can huddle and say, okay, how are we going to strategize this, right? You're going to do this, I'm going to do this, yada, yada. And then, like I said, the fact that at the end, they actually see the apples there in the tree, or in the basket, really has gone a long way as far as not just re-engaging people or not just rebuilding trust in the data, but also just getting people excited. Because let me tell you, even though this is like Tetris on a good day, this really has made people excited to come and see those apples in the basket, or hey, you medical assistant that I'm friendly sparring with in my pod, right? How come I picked all my apples and your apples are still sitting on the tree? What's going on with your apples? It's kind of funny. We've had some audits in the past 6 months since this has been rolled out, and one of our federal auditors noted that they heard a lot of talk about apples on the floor in one of our clinics, and they were very confused about that and wanted to know if that was related to like our fresh veggie giveaway or what that was about. So I thought, I was sort of laughing and sort of thought, oh, this is so great. So, yeah, so we all love the apples. Moving to the visit anticipation tool, this is what really helps you translate those numbers that are on the tree, right? So you see the 5 there. If I want to know, well, how many, you know, like who and when and what does this 5 really represent, I would simply just click on the apple, and it takes me to this visit anticipation apple tool. And this, here you can clearly see the 5 for depression screening and follow-up, and there are your 5 apples for the patients coming in at their appointment slots here, where this line, the gray line, represents appointments that have already happened. So again, just this personalized, dynamic, every 15-minute data with some fruit thrown in. You know, it's like, who knew that that smoothie was even on the menu, but it works well. I'm here to tell you. So it follows that, again, using this as sort of a huddle tool or even an evaluation tool for how we did on the day together, you know, medical assistants, RNs, providers, they can look at this and really make sure that they're getting everyone. Now, you could note that over here, this total due here, so the total due gives us a count of how many measures per patient are actually due that day. So you can imagine if one of these patients had, 4 apples, then we really got to make sure that we spend a good amount of time with that patient and make sure that those apples get got, if you will, because the chances are that patient probably hasn't been in to see us in a while, and not just from a performance perspective, but from a quality care perspective, we want to make sure that we get all those things done for him or her on that day. You'll notice here healthcare maintenance, so we built in an actual mirror of what you would see in your care guidelines or your healthcare maintenance in Epic, whatever the corollary is for your EHR. That gives you other due vaccinations, tests, BMI, counseling, whatever it is that are not our 10 core quality measures, just so you don't have to toggle back and forth between the EHR and this. You can live in Tableau effectively for your peds, adult medicine, family medicine care now, because we have built in this. So what would happen is if you wanted to know more, you'd click on this exclamation point telling you that, oh, there is actually more due for this patient than just these quality measures on the screen. You would click on it and it would give you sort of a list of what else was due. I'll note that you'll see immunizations is not there because TEV did not have any children due for immunizations. So we thought rather than have it there and have people asking questions about it, we'd just take it off. So that was a design decision. I want to talk a little bit about just blowing this up and talking a little bit about the numbers and how they relate and the hovers, because we've really made liberty of the tooltips. So you'll notice here that this is 0, even though there is a half-eaten apple here. Now the half-eaten apple here means that the medical assistant has basically done all of the work that she or he needs to do. In other words, there is an order for a mammogram in the system, but the provider now needs to remind the patient, hey, we have an order for you to go to this and that center to get your mammogram done. Really important. Let us help you prevent breast cancer. And conversely, you see here the 0 for a cervical cancer screen and the apple there. So this is basically, and it's really hard to see, but it basically shows you here that that since the most recent refresh, the provider has actually taken action and the test is now ordered. So this is going to show you that your actual count is down to 0, and you actually did what you were supposed to do for the apple, so that you can kind of keep tabs on how your apples are going throughout your day. What happens if you want to know how you did going back in time? So this is where our last, I've showed you the dashboard, the VAT. I'm going to now show you my favorite piece of all of this, which comes from our friend here, the little apple with the report card, which is the same as this tab. It's just a live link in the visit anticipation apple tree kind of arena that you can also link. So this is for the situation where Tev is sitting with her MA and says, I've just looked back in time, and it looks like on October 8th, we left some things on the tree. What's going on with that? We were doing so well. We usually have a bunch of apples in the basket. They're on the tree. So what Tev and her MA can do is either click on this little guy here or go to the Missed Opportunities tab. And what they see is, again, another silly apple-related game, but I'm telling you, it does the trick. You see here our little badges of honor. So for every day in the last 2 weeks that Tev had clinic, what we do is we tell her and her medical assistant how many opportunities they had that day and the proportion of those that they done or satisfied and those that they left on the tree. So if we're looking at that October 8th date, and there are that 17% of the total opportunities, or those 2 apples that we saw on the previous screen still remaining on the tree. And you're thinking, okay, like we're, the powers that be are rating us a crisp counter. We want to be a pro picker. So what are we going to do, medical assistant, to make this better? You can actually click on that 17% and it gives you a list of the patients, again, by when they saw you on that day, how many were due, what time, et cetera, and which things you actually missed, right? So that conceivably, Tev could say, hey, medical assistant, with all that free time that you have today, can you make a couple calls? Because we got to get these patients back in for care because we missed them. So just kind of, again, trying to have a lens towards both getting people excited, reinstating that trust, really making performance something friendly. Apples, doesn't get much friendlier than an apple. Really, I think sort of open the doors to those conversations, even among providers and medical assistants, because now it's not, hey, medical assistant, we let those people slide by. It's like, hey, this is kind of fun. We can go in and we can see what badge we got, and then we can see who we need to do some cleanup work with. It's non-threatening, creates a safe space for that kind of conversation. I want to move now just real quickly to show you what else is in our suite, because again, I'm sort of my own client. In addition to managing our data analytics department, I'm also the clinical brain for all of this stuff. So I just thought it was important for any of you who are in clinical quality or population health roles to see that we did develop the other side of this, which is really more around outreach. For the PCPs, we have condition-specific registries. So for those of you that are on nice EHRs like Epic, they have registries, but the thing that they're lacking is really these stats page, what I like to call a stats page, like something that really tells you as an organization, you as a medical home, you as a provider, how you're doing within that condition-specific population. So we built 6 of our 10 core quality measures are currently built out into what we call condition-specific registries. So here's a snapshot of the diabetes one. All of our registries are built with one tab, that's that stat page, and then one tab, that's the actual patient detail. So you'll note here that we have our lovely dancing people on all of our registries. We have dancing people because the only thing more universal than apples is dance. So we like to have people know, just using a simple icon overlaid with a bar chart, how they're doing. And we just have some really, really simple visuals around different cuts of comorbidities or how we're doing with our med regimens. We also have some interesting things that we're playing around with, like the maps or these little charts related to insurance. Now, anytime you want to see this stats page just based on a cut of the data, like if I wanted to, let's say, only see this stats page for those on my panel that are in poor control currently, all I'd have to do is click this poor control box, and it would automatically refresh this tool to give me all of these stats, but only for these 592 people that are poor control. So that makes it real easy for providers to slice and dice how who they want to see relative to all of these things. And then, of course, it follows, I'm sure you know where I'm headed next. If you click any of the bars as well, you can also do this thing where it says go to detail, and it will actually take you to the patient list for that condition or the thing that you specified on the stat page. You can, of course, also use the filters that we have built in over here or available on our hamburger menu here. But from the stats page to the patient list is probably the most user-friendly and probably the most regular way that our end users actually use it. So we have just really simple, a little bit of conditional formatting here so that people who are looking at this can actually see what's going on with these patients. Obviously, red is an increase in A1C, so that's a decrease in what we want to see happening, or green is an improvement in your A1C. And so again, just like what can we do to flag just these clinical indicators in a really simple, easy to digest way? And how can we pull back the curtain, right? Because again, part of this whole hesitation around performance, and especially given those terrible 10 Commandment chart things that people were used to, is that you'd talk about, oh, well, your diabetic population. Well, that's the easiest way to lose a provider, because the first question they're going to say is, well, how do you know who's on my diabetic population? So by doing this, right, we're actually giving them, and I have literally sat with one of our providers, Dr. J, who said that very thing to me. Well, how do you know who's due on my panel for a mammogram? And we sat and we looked at every single patient on this list. And at the end of it, I sort of said, so is there anything we can do better in this arena? And he didn't really have anything to say. Tried to change the subject and say, do you want to grab some lunch? And so I just let it stand right there. But so anyway, it's a really great tool to just instantaneously marry those stats, and the actual patient detail goes a long way. Here's that hamburger menu that I mentioned. So we built in a bunch of other filters that you can do. We built in this nice little range kind of gimme thing where you can set, what you're looking at, because if you only have time, let's say, to call patients who are really not doing well with their A1C, then you might want to set it higher, et cetera. So we definitely had some fun with setting up that patient detail as well. Quickly, for support staff, we have the tools for outreach. So these follow the same sort of design as our registries, still with our dancing person, of course, but our KPIs are different, right? So we have calls made. This is our call quota. See just like a simple run chart of how these support staff are doing, making these calls to, in this case, patients due for colorectal cancer screening. We have this all based on, again, I am my own client, so all of these are based on clinical, evidence-based outreach priorities, right? So we would definitely want to call the people that have been seen by us recently with an abnormal history, because those are the people where we know we can get in and we just haven't seen them recently. So we sort of stratified all of this based on likelihood of outreach given our limited support staff bandwidth to make these calls. And then again, if you don't want to play around with the filters and you're just an outreach person and you just want to go in here and only make calls off of priority 2 today, all you'd have to do is click this bar chart and it would take you to the patient detail of all of the people you needed to call for that priority. So just a simple way, try to make all of this brainless but engaging. And there's what I just said. So you would just click go to outreach list and it would take you there. And here's just a sample of another kind of hamburger menu of filters. I bet you can all see now why we didn't include this on the proper list, because there's a lot of choices. And again, 85% of the people making these calls are never going to use the filters. But for those 15% A+ students, we wanted to build in the filters just in case people wanted to have some fun or wanted to answer their own questions about their own panel. The most popular one is the history of abnormal, right? People want to make sure that people with a history of abnormal screens are being classified in the right way. So that's been a big winner amongst our clinical groups. So how did we do? I would say there's really was a lot of apples that were picked. This is the beginning of our quality performance year. Those of you on HEDIS will know January is the start of performance year. So this is when we really said, hey, these are our 10 core quality measures. We are going to focus on them. Please join us. It will be great. And here is where we implemented the Apple suite that I just showed you. And you will note that this was only about 6 months ago, and we have not reached the end of our performance year. So we don't quite know how this story ends. But if you do see here, there's about, in many, and this, I'm sorry, I should say, these are for all of our quality measures. So basically, so what this is showing is for all of our sites, right? Each one of these is one of our primary care sites. If you took all of the numerators and all of the denominators for the 10 core quality measures, put them all together into a composite, this is basically showing you our improvement over time for that at each one of our sites. So what I'm trying to say to you here is, by focusing on 10 core quality measures, got a lot of bang, and then we got actually, in some cases, somewhere between a 0.05 to a 5% increase just based on Tableau alone. There was nothing we did differently, from here to here, except Tableau, for example. I'm really lucky that we have this nice control group here. Can anyone guess what this line is? So these are all of our clinics. So these represent all of the patients impaneled at all of our clinics. Now? Urgent care, very good guess. Sort of similar. These are all of the people who have come in to see us who we have not impaneled. So these are all of the patients who are not getting the benefit of any of the tools that I just showed you because they're not in anyone's panel. They're not coming in for care. They had some kind of medical visit, could have been in urgent care, could have been in primary care, and our ops is hopefully slowly but surely finding them a home in our system. But you see down here, really not doing well. Though, in a good way, this kind of shows you how good our care really is, because if you were part of any of the protocols we had in place, you'd be doing much better. So we hope to get these people into the mix very soon. So quickly, I'm going to show you just 3 little quick emails from our associate medical directors or chiefs or whatever they may be called at your site. So here's Serena saying, how can I see other people's data so I can compare myself and gloat, right? So she's like looking at her daily dashboard and is like, I want to go to other people's daily dashboards and look at how many apples they pick, because I bet I'm picking a lot. Rachel Fogel is saying, my team gets so frustrated when we can't pick all the apples, right? So just another, and I should note, Rachel Fogel was like one of our biggest technology does not work in community health sort of people, so I was really excited to get this email. And lastly, Kin Nguyen, thank you for clarifying. I know personally my MA has been much more aggressive with healthcare maintenance once Tableau started. So kind of nice little props from our leadership team. So where do we go from here? I'd like to think that this journey that we're on, that I'm talking to you about today, really has kind of opened the conversation at the very least, if not just excited people who either were excited about data in a past role and then kind of came to LifeLong and were like, oh, or haven't ever had any experiences with data, like our medical assistants. These folks, when they go and get their licensure, it's not like they're getting stats classes. And I have a ton of medical assistants who are actually volunteering themselves. Hey, do you need any help in your data analytics department? Can I do any kind of validation for you? Do you want me to test this thing? So it's kind of really, in some ways, elevated the conversation for all of us, not just our AMDs. So that's really exciting. And as far as the onwards piece, so we are transitioning to Epic right now. I'm actually here enjoying all of you instead of dealing with that. So thank you for that. So those of you who are on Epic know that, at least the rumor is, you cannot directly connect to Epic in the same way that you can other EHRs. So we are unfortunately losing our 15-minute refresh, which effectively sort of sunsets this whole thing for us. But it does not have to sunset for you. So, Tearaway and I really built this as a solution, not for LifeLong, but kind of just using LifeLong as a prototype for, I'm sure, many of the experiences that you are all having, especially in a public health, community health, FQ world. So we, in all ways, want to open source this or make this available to you, whether it's the actual workbook or conversations about how we structured things, or those sort of junior varsity at best graphics, if you want them. So we really want to hand it over to anyone who wants it, and are also happy to share with you where we're going from here, given those limitations with Epic. But that's for another conversation. So I'd love to take the next 20 minutes or so for questions, and I just want to say thank you so much for the opportunity. And there's the team right there.